All right, so we've been hearing a lot about somatic interference, and I'm going to now show you what we've done in our work. So I'm taking sort of like now for something completely different, is the best way to say it. And that's because we've been focusing a lot on individuals with germline mutations, and the question is when you get a test report back, when is it not potentially a germline mutation? So just again, a reminder, most of the people who get genetic testing, especially multi-gene panel testing, are going to be looking at the spectrum of genes that are listed here. And again, when you look at it, of course, a minority fraction are going to be Cowden's disease, P53, or any of the other genes, like, for example, CDH1 and diffuse hereditary gastric cancer and lobular cancer. But a lot of people are getting testing. So, again, you all know Li-Fraumeni syndrome, so I don't need to belabor it, other than the fact that, at least in our study in 2009, when we published on the prevalence of the phenotype among a series of patients who were tested, the 4 core tumors, brain tumor, sarcoma, adrenocortical carcinoma, and breast cancer, we didn't find a P53 mutation in a family that didn't have at least one of those tumors. So that was just illustrative. And I think ultimately also looking at Terry Friborg's group, we've done things in parallel very much in defining these phenotypes and showing the same thing essentially. So, and then again, a consortium effort, life consortium effort to look at the Her2 phenotype. So we're looking at early onset breast cancer, Her2 positive, and typically triple positive as a distinguishing phenotype. So then the real question becomes is when the phenotype doesn't fit. So this started 2 cases that came to me. One is this man, a 79-year-old unaffected man of Jewish ancestry, had gotten a PancNext test, which meant it was a multi-gene panel test that included P53, and this was because his brother had just died of pancreatic cancer. So pancreatic cancer is really arguably not a big part of Li-Fraumeni syndrome to begin with, but what we got on his multi-gene panel test back, and this was the second opinion case to me, was a P53 mutation, a pathogenic variant. But there was a comment, and the comment was that the allele fraction was lower than expected. And so that really led to the question of what do you do when the germline mutation is a surprise? So in that setting, we looked at his case, again, just to walk you through the analysis that I did in partnership with Ambry Genetics at the time, here's his blood and his Sanger results. So here it is at 12.7% allele fraction at a depth of 2,150 reads. And you can see the smaller allele fraction right here on Sanger, so you can see it on Sanger as well. And then the next question is, well, is it in other tissues? So skin tissue, so we had a skin biopsy, and in the skin tissue, we didn't find it. So 3,583x coverage, no evidence of the allele. And then we did eyebrow plucks, because one of the things we're trying to get at is if you have to do ancillary tissues, maybe we can use tissues that are less invasive to collect. And I literally give the patient the tweezers and a mirror, and they pluck eyebrows. And if they pluck in the right direction, you get a good follicle, and they groom themselves at the same time. So, so in any event, again, looking very deeply here, so using NGS, the variant was not observed in the eyebrow pluck, and here it's not evident at all on the Sanger sequencing trace. So I thought, well, geez, maybe what else could this be? We're talking about cell-free DNA and tumors and things. And he tells me along the way, as we're examining him, he starts to tell me this story. And the story was basically, he had a PSA a year earlier of 3.5. It had risen to 16. And about the time I was doing his eyebrow plucks and all of this, he's telling me this incidental story. And sure enough, he had a prostate cancer that was identified in August. And I thought, this is it. We picked up his prostate cancer on his cell-free DNA by virtue of his germline testing. No such luck. We pulled the tissue, sequenced it, in this case, down to 13,882 fold coverage, and there were just a few picked up in there, and basically you can't see it on Sanger, but in review of the aligned sequence data, with more than 10,000 reads, only about 1% evidence, which was commensurate with the inflammatory cells in the prostate biopsy. So this was not present in the tissue of the tumor itself, and this truly was the inflammatory lymphoid cells in the biopsy. So this really led me to a larger study, and we had a similar case of a woman with a breast cancer 58 who didn't have a distorted allele fraction, but didn't look like Li-Fraumeni, so we challenged the case. So working with Ambry, we then went and did, usually accept that DNA isolated from peripheral blood or saliva is accepted as representative of the germline because of what was thought to be the rarity of somatic mutations. Pathogenic p53 variants with abnormal next-generation sequencing metrics, which, as Judy mentioned earlier, are not consistent from laboratory to laboratory, but working with Ambry, they selected 25% as the threshold at which to call it out as an abnormal metric. The other thing they might see, though, is more than 2 detected alleles, so seeing 2 p53 mutations in the same individual would be considered a priori suspicious. And they also do copy number variant looks, and so if there's a pattern of copy number variants across the genome that are looking atypical, they'll also call those out for a closer look. So these were those from the CLIA lab testing cohort. Alternate tissues, close relatives were tested, looking for transmission, so we were checking off of the children and looking at siblings, and then also pulling tissue blocks or eyebrow plucks or skin biopsies. So this is the consort plot just to show you that we examined 116,000 different multi-gene panel tests that were performed. All tests combined 114,630 multi-gene panel, 1,454 single-gene tests. Now this, by the way, is the bookend study to what Judy showed you earlier, because in her case, they excluded all the cases I'm going to tell you about before using this same cohort to then define p53 phenotypes. And as you come down the side here, you see that these were the positives, presumed germline were 219, and then suspected, what the term that came out in our review process was aberrant clonal expansion, so ACE. We wanted to call it somatic interference, but the reviewers insisted that it should be aberrant clonal expansion, so that's what it is. Now you can down here, no ancillary testing, but in 30 cases here we did ancillary testing and came up with these assumptions, which I'm going to review for you. You go down the same pathway for the single gene, and again here a much lower proportion were thought to be suspected ACE, and that among those a greater proportion were ultimately determined to be germline. So I'll sort that out in the next slide. So by way of summary, and this was published in Genetics and Medicine in the fall, 23% of multi-gene panel tests detected p53s, we conclude, were likely to be spurious in the sense that they are analytically correct. They found a p53 mutation, but clinically they are not germline. So that was our overall conclusion. And if you come down here, you can see that compared to the TP53 gene-specific testing, where only 8% were considered to be the ACE, that was significant. And then down here you can see that most of the people were breast cancer patients. There's an age difference between the two groups as well, not surprising. Older average age for the multi-gene panel tested cohort versus the younger age for the TP53 specific cohort, that was significant. And then down here again, among those of the multi-gene panel cohort that were suspected to be ACE, 96% were confirmed to be so. We did find at least one germline mutation that we confirmed by virtue of a sibling that shared the same mutation. Here's an example of one of the pedigrees. So here's a woman with breast cancer at 61, was reported to have a p53 mutation. DNA from her eyebrow pluck, which is again, nice non-invasive way, was negative down to a read depth of 10,000. So obviously you wouldn't have picked this as a Li-Fraumeni family, and again, thinking about these phenotypes, when would you challenge them? Among the tumors of the patients who were tested, if you look here, the majority were breast. That reflects the general profile of people getting genetic testing at most labs in the US. But what I want to highlight here is, there's very few. Here's one rhabdomyosarcoma, very few that you would have considered other core tumors. And the other thing that was interesting is 5% had either MDS, and then another 3% had an overt leukemia. You would say, well, why were they testing those? Well, the reality is that they didn't report that. So whoever sent the test in didn't report it. It was only in our review going back and asking them more questions, where there was a few that had apparent myelodysplasia or a low-grade CLL that became perhaps the reason for this false positive. But that's something that needs to be considered. But all down here, look at 21% of the cases were ovarian cancer cases. And when we worked through the 12 ovarian cancer cases, none of them had it as a germline finding. They were all spurious, and that really leads us to some other observations. So this was a study that was published showing the dynamic acquisition of P53 mutations as detected in the blood in a series of ovarian cancer patients from the gynecologic oncology group, and basically just showed that no presence at before therapy. After therapy, they could detect a P53 mutation. Same for PPM1D, which had been thought to be a cancer predisposition gene, but I now believe that most of the literature that supported that was probably due to these false positives, if you want to call them that. So here we show that you can actually dynamically acquire these. We believe this to be the source of most of the ovarian cancer-associated abnormalities that have been seen. Don't forget that ovarian cancer is a disease of older women, so they're often in their 60s and 70s when they're diagnosed. And when you think about clonal hematopoiesis, that's about the age range you start to see a serious spike in that frequency. When you look at the NCCN guideline, they do say that there's no increased risk for ovarian cancer. This is supported by another series of studies from the gynecologic oncology group. You can see the genes that are thought to be associated with ovarian cancer risk up here, and clearly when looking at P53, especially when it's corrected, you don't see an excess over exact in this cohort. So really don't believe that P53 is an ovarian cancer gene. So what's the source in most of these cases? Most of them we believe are going to be clonal hematopoiesis. Now, one of the things we observed was when we did tissues of other types, we had one case that seemed a bit confusing. The colon biopsy showed the P53 mutation at a low allele fraction. The gastric biopsy didn't. So here we have the same germ layer without the evidence of it, and we tested 3 other tissues, and none of the others were positive. I said there's something wrong with that. We had another case that was a sarcoma, but it was a splenic sarcoma, and testing the normal spleen showed the mutation, but the sarcoma didn't have it, okay? And so it turns out that the lymphocytes in that patient showed the disease. So in that colon case, it turns out that I said, go back and review the pathology, and the top line of the pathology report said inflammatory infiltrate in the colon biopsy. So what we were actually detecting was the presence of the lymphocytes and the mutation in that tissue. It wasn't a mosaic case. Now, this is again the frequency that we've been learning about, that 80-year-olds, over 10%, will have some evidence of clonal hematopoiesis. And when you look at the genes that are associated with that, DNMT3A is the most common gene, but here we are with P53 as the 4th most common gene involved in clonal hematopoiesis. And again, clonal evolution, subsequent diagnosis of myeloid malignancies, because there is some concern. Good news is you don't have Li-Fraumeni syndrome. Bad news is we might be concerned about a developing hematologic malignancy. And various estimates suggest about a 1% per year risk for that sort of transformation. And one of my cases that was was a CLL case, had exactly this mutation. And as you see, the clonal evolution and the idea of the expansion within the blood of this, and often with complex karyotypes, often with complex findings. But mosaicism is very common. So I'm learning this a lot from Gareth as well about the neurofibromatosis cases. So, mosaicism is common. We see this, it's a well-defined clinical genetics entity. And so really, I think what we are is on the edge of the iceberg of findings of this. And if you look deep enough in almost any tissue, you will find mutations, and P53 is one of those that you'll find. What is the timing of that event? Because technically, clonal hematopoiesis is mosaicism. It just happens to be confined to the hematologic compartment. And the issue is at what point in the post-zygotic timing of the event, and what was the outcome? And then the other one is, of course, gonadal mosaicism. So is it restricted to the gonad so that the parents' germline testing is negative, but the offspring have a full-on heterozygous mutation? So here's another case that's going to be typical of that. We're in the midst of working this one out right now, but here's a woman, 28-year-old with breast cancer, no cancer family history to speak of other than the late onset colon cancer. Parents have been tested so far, known to be negative for P53. We're testing tissues such as skin, eyebrow plucks, etc., to sort out her case. Here's another one where this one's more of the idea of a true mosaic. So here's one that we were, again, suspicious was going to be somatic interference, but low-level pathogenic variant was what the report said, and we did fibroblast culture, and it was a low level in the fibroblast culture. So this is probably one that is a true mosaic, but then you look, it's not a classic presentation at 45, and neuroblastoma isn't a typical associated tumor in the child. So we have a lot to do in this family yet to do transmission testing and to look closer at what does it mean to be 20% MAF. Now, mosaics are in existence for P53, but they've rarely been documented well. So here are two examples where they've been delineated by layer. And then I'll highlight Terry Friedberg's work, just on a recent paper in 2017, where they did deep sequencing of 108 patients suggestive of Li-Fraumeni, but who they didn't find a mutation. And what they showed was out of several of these, here's several children with ACC, choroid plexus tumor, women with early onset breast cancer, where they were able to pick up the low level fraction and presumably a true post-zygotic mosaic with risk that will be difficult to define depending upon how many layers are involved. And then the summary on their cohort, though, is that you start to get what you're hearing. De novo mutations, probably in up to 14%, and that a fifth of those, at least by their estimate, are likely to be mosaic. And so, you go to Google, you can get a lot of mosaic images, which I thought were interesting in sort of juxtaposing the, the embryology that goes with this, but when is it hiding a cancer? So that's one of the things that's sort of interest to us. So somatic P53 mutations can be detected in blood or saliva by next-gen sequencing, potential for false positive interpretation as germline representation. Quality control measures, pay attention to the test report. So when they see below, take a look below and see what that's about. Some of the vendors are insisting on other tissues in every case, because I think when we see other cases that have the phenotype that doesn't quite fit, you should be thinking about it. And really, when you're managing the medical management of a patient where the only criterion for this is the P53 mutation, I think we need to be cautious about how we apply that, especially as you learn about the imaging and how intense it is. It's at least $10,000 worth of imaging a year, plus the exposures. So I think, I'm from LA, so you got all the phenotypes. So if the phenotype doesn't fit, you must acquit. All right. Thank you very much for your attention. Gareth.
Thank you, Jeff. That's such important work, and the worry is, of course, that that many panel testing firms aren't as responsible as Ambry, and that many people who are interpreting this with their family histories are not going to be as experienced as you are. And so I just wonder how many people out there have been told they've got a germline P53 mutation and they're actually ACE patients rather than proper P53.
It's a great question, Gareth, and through publicity about the work we've been doing, I get a call perhaps every week or every other week about exactly that question. At least there's some awareness that's out there. And I think, I think our estimate, 20%, means there's a wealth of these out there that have not been evaluated. Further, the labs don't have a consistency with how they make the call in terms of whether it's 25%, 30%, what are their criteria for doing it. Ambry and Myriad both are very fastidious in this regard. Some of the others I haven't seen, and Invitae I think also. There are several that I do believe that are fastidious about making that call. I've worked with people at all of those labs in terms of working these up. So I think that's important, but just recognizing it. And so I think I still teach phenotype. I think phenotype is still important to teach. Somebody else had a question? Judy, please.
So one thing the labs do not routinely report is allelic fraction. And
right.
So if you're suspicious, you can call and ask, but do you think we should be encouraging them, or does Sharon think we should be encouraging the labs to be reporting allelic fraction for P53 at least in patients where this may be the case? Also, we should probably pay more attention to whether we're testing people after chemotherapy exposure than we might have otherwise.
Yes, thank you, Judy. Both those are really important comments. And one of the problems is that they don't have a fixed way of working these up either. So one of the things that we're working on is trying to come up with what is the minimum you need to do when you have a case that might be suspicious. Is the skin biopsy enough, or should you be looking at the at-risk tissue? So for example, if it's a woman with breast cancer, if her tissue block in her breast doesn't show the P53 mutation, even if I can't be absolutely certain it's clonal hematopoiesis, I shouldn't really attribute her breast cancer to the P53. So one of the problems is you can never quite tell where does mosaicism and multi-tissue or oligo-tissue risk end, and when does clonal hematopoiesis define the whole?
Yeah, I'm assuming it was my Sharon this time. I'm not sure. I think you have to be cautious about what you put in reports. Mm-hmm. Just as an example, the geneticists really bugged Baylor to put polyphen and SIFT into their early exome reports. The oncologists I worked with were like, "Oh, damaging. This is bad." So
Right.
So
the chance for misinterpretation
I'm not sure
or confusion.
Many people requesting genetic test results know what allele fraction even means.
Right.
So I think it's probably better to have a comment that these can be complicated, should be reviewed by a genetics professional familiar with genetics, as opposed to just putting the data out there, which could very easily be misinterpreted.
Yeah, I agree with you in that sense. And so, we should. And so what we teach all the people in our course is call the lab director. We actually tell people that if it doesn't fit, call the lab director and ask those questions. Yes, Arne.
There's some rich biology in P53 literature that would suggest that most of what you see by clonal expansion of a P53 mutation is in a progenitor cell or a stem cell, and that it hangs around and competes and replicates. It seems to me that's a terrific setup for you to isolate these cells by organoids, right? So if you use Hans Kleber's organoids, and it doesn't really matter, whatever tissue you see, right? You try to make the organoids, and then the stem cells will grow out. And you can do a kind of analysis at the single cell level that would be very important to you. I mean, you'd like to know about heterozygosity, homozygosity. You'd like to know, there are a lot of wonderful questions to ask.
Yeah.
And I think getting the cells out of people, right, and into this organoid culture, which is like a halfway house, would be one direction that would be profitable.
And you could do that with flow, certainly, for these patients.
Exactly. Yeah.
Yeah. No, I think that's interesting. So we're actually doing studies. The other thing I want to know is, so for example, in the studies like Ben Ebert and others looking at clonal hematopoiesis and the risk for leukemia, if you had more than one heme-related gene mutation, so there's more than one defect in the clone, greater risk. And so one of the things we're doing is we're accumulating these cases. We've got an entire panel of all the heme genes, so we're looking at what other clonal abnormalities are there that aren't on the multi-gene panel. ATM can be seen, CHEK2 can be seen as part of these clones as well. And then what are the other heme genes that's one thing. The second is we're following them serially. So does that clone expand, contract, or stay stable? But it turns out that they can be variable depending on what day of the week you sample the patient. So the question is if you test and retest at a lab, will you get the same fraction? That's one question. And it turns out they tell me yes, they've done 2 or 3, and they can take same sample, get the same fraction on NGS. But if you test the same patient 3 days in the week, well, their lymphocyte count varies by stress levels, things like that. So it goes up and down. The fraction goes up and down. So we probably need to handicap the fraction and against the lymphocyte count in order to do the CBCs. So a lot of interesting things we have to do this going forward.
Yeah. The other question I had for you is, I wonder if you care to speculate if heterozygosity in a stem cell gives expansion of populations, what are the consequences for Li-Fraumeni families?
Boy, I don't know if I could speculate on that. I think, it's a challenging thing. I think it's just interesting that when you look at clonal hematopoiesis, I was a hematologist, I circled all the way back to my roots and thinking about bone marrow transplant. You have a very reduced spectrum of clones that are starting. It makes sense that P53 with its anti-apoptotic effect would allow survival of that clone. And it's almost certainly part of normal aging. So, I can't speculate in the context of a Li-Fraumeni patient, though. All right. Thank you, David.